Dr. David J. Shulkin from USA to deliver his keynote speech. Thank you.
Okay. Well, good morning, everybody. I am just trying to figure out how to share my screen, which I don't necessarily know how to do.
So if you move the mouse over the screen and see the share screen green part, if you could click that, and then on your desktop you can click on your presentation, please.
Okay, great. That would be okay. Very good. Thank you for your help. my first time doing this. Is my screen available to you?
Yes, perfect.
Okay, but I want to get it into the share screen mode.
Yeah, so here, okay. Yeah, perfect.
Is that right?
Yes, please.
Okay, very good. Well, I'm just waiting for this screen to come up. Are you able to see it yet? I'm not.
I think it's stuck here. If you could just click on the bottom right side on the screen where you kept the cursor earlier, if you could click it again so it may become enlarged for the full screen view. Yes, I think something is going to happen.
Okay, I'm so sorry about that. Okay. It's always a speaker's nightmare when this happens, but I am going to just try once more.
Yes, please.
Share screen, and then, okay. I think I'm going to leave it like this, and if that's okay, can you see okay?
Yes, we can see.
Oh, okay. So I apologize to everybody for all those technical issues. Hopefully it'll go better from here on. I always like to start with a disclaimer. I think it's a good practice. And basically what my disclaimer is that I am certainly not an expert like so many of you on the call in digital pathology. That I am not a pathologist, I'm actually an internist. But what I am an expert in is in understanding the healthcare delivery system. I have been, besides being a physician, I've been a CEO of several of the largest hospital systems in the United States, in New York City and the New York City geographic region. I've run large physician organizations. I've been the dean of a medical school. And as we're going to talk about, I've had some recent experience running the largest healthcare system in the United States. But one of the reasons why I call myself an expert in these areas is because no matter what job I've held, I've always kept my white coat and always taken care of patients so that I could understand how the healthcare system works. And so this is a picture of me when I was the secretary in the Department of Veteran Affairs, taking care of veterans that I would take care of both in person and via telehealth. And we're going to talk a little bit about that. And so I had mentioned that the Department of Veteran Affairs is the largest healthcare system in the United States. Many people don't realize that it's the second largest government agency. The Department of Defense is the largest, and number 2 is VA. VA employs about 425,000 employees. Just to give you a sense, the Department of State, which everybody has heard of, employs about 20,000 employees. So VA is a very, very large health system. It has facilities in almost every congressional district in the country, over 1,200 different facilities from coast to coast, many in very rural parts of the country. And so it's probably one of the only health systems in the United States that really has to deliver care no matter where they have facilities. The responsibility is to deliver care to every veteran in the country. There are 21 million American veterans, so it's a pretty large health system. Now, in terms of the area that we're discussing today, the Department of Veteran Affairs then, because of its scope, has a pretty large base of patients that have prostate cancer. Certainly, traditionally, the Department of Defense and the Department of Veteran Affairs have been overrepresented by males. So 489,000 prostate cancer patients currently are in the Department of Veteran Affairs healthcare system. About 16,000 of those have metastatic prostate cancer disease. So to give you a size and scope of what's happening. About 1 in 5 of US veterans will develop prostate cancer in their lifetime. It's the most common cancer diagnosis. Those that serve in the military are twice as likely as those in the general population to develop prostate cancer. And there are the numbers that you've already seen, the 489,000 and the 16,000. Now, for those of you, particularly those of you who are international, who may not have a sense about what differs between a VA hospital and a regular hospital in the private sector, they take care of generally the same types of conditions, from preventative care through chronic care through hospice and long-term care. But the culture of the organization is very different. It is a very mission-driven organization. And this is just one example of how I learned that. I'd been in the private sector all of my career when I went into government in 2015. And I went to a VA hospital and saw this, which is when a patient dies in a hospital, in a regular hospital, they usually cover the body with a white sheet. They wheel the stretcher with the white sheet over to the elevator and usually down to the basement where the morgue is. And that's how they deal with the body. In a VA hospital, instead of using a white sheet, they will drape the body in a flag. And you can see people line up on the hallways. And as the body is wheeled past, they salute in what's called the final salute, to say goodbye and to give their respect to somebody who has served their country. And so it just gives you a sense about how mission-driven this organization is and the sense of respect for duty and service that people give to our veterans in this country. Now, when it comes to taking care of our veterans, of course, not everything always is done perfectly. That's the same in private hospitals. And so there are many people out there that look for faults in the VA system, things that the VA system did wrong. And prostate cancer and misdiagnosis or mistreatment has been a chronic issue in the VA system, largely because of the amount of veterans that are cared for in so many different parts of the country. And so these are ads that are often seen on American television by lawyers looking to identify veterans who have been mistreated for prostate cancer. I think everybody on the phone understands that the issue of misdiagnosis, the issue of potentially getting the grade of a prostate cancer or any other cancer incorrect is a significant patient safety issue. And the Department of Veteran Affairs has had some public issues. In fact, one of the differences between running private hospitals like I used to and running the Department of Veteran Affairs is that when mistakes happen in private hospitals, they often stay quiet and you can settle a lawsuit. In the Department of Veteran Affairs, everything is public, and it often will turn into a congressional hearing or a front page article in one of the major US newspapers. And so there have been some very highly publicized cases where veterans have been misdiagnosed, and that obviously is a big concern. So when we look at the broad issue of misdiagnosis as a patient safety issue, you can see that data that has been looked at across the country shows that 44% of some types of some type of cancers are diagnosed. Now, this is not always a pathologic misdiagnosis. This could be a clinical misdiagnosis where people are then given the wrong treatment styles. But or it could be radiologic, as you can see here on the third bullet. 51% of breast imaging second opinions are actually different. So it's almost like flipping a coin, that if you give the same image to two different radiologists, they can have two different interpretations almost half the time. So this is a big problem, not only in pathology, but in other areas of clinical diagnosis. When I first became secretary of the Department of Veteran Affairs, whenever you speak about things, you can get a lot of attention for what you're speaking about. These two pictures just sort of give you a sense of what that's like. When you sit down at a congressional hearing in the United States, as you can see me off on the left giving testimony, what you don't normally see are the cameras and the photographers and the journalists that are around you. But every time you're speaking, there generally is a press corps around you. And that's a very powerful position, because you can articulate and give information to the public about key issues if you're thoughtful about it. Off to the right, it's a little bit of a blurred picture, but this is actually the White House press briefing room. A lot of people only see the picture from looking at the speaker. You can see me at the very bottom of this picture where I am delivering a speech at the White House briefing room. But I took the picture looking out to see how small a room that is, but also how many reporters are in there covering what you're speaking. The reason I'm mentioning this is because within the first month of becoming secretary, I went to that White House briefing room that day to talk about this issue, to talk about the problems that have existed in the Department of Veteran Affairs for decades, and that if we didn't change our approach and we did not modernize our system, that we would continue to see these types of problems again and again and again. And it didn't matter if it was a Republican or a Democrat who was the president. What mattered is the systems of care that we had for caring for our veterans, and that we really had to modernize our approach. And part of that approach, which we're going to talk about, is using artificial intelligence and machine learning, and using technology in a way that we can change the way that we deliver care. One of the first things that I started to do then was to bring this technology into the Department of Veteran Affairs. Off on the left, you can see that this was actually, I forgot to mention for those that don't follow American politics that closely, I actually was the only one in the President Trump's cabinet that had been a presidential appointee to President Obama. Normally, a new president clears out all the old political appointees. I thought I'd be leaving at the end of the Obama administration, but President Trump asked me to be the sole person to stay on and to join his cabinet. In the Obama administration, I actually brought IBM, using their artificial intelligence tool, Watson, to help us do a better job of caring for patients, veterans with cancer. And some of you may remember that at the time in the Obama administration, President Obama asked Vice President Biden, currently President Biden, to lead the Cancer Moonshot Initiative. And I was the representative on the moonshot from the Department of Veteran Affairs. We would meet with now President Biden every week in his office, and we would talk about what we were doing to improve the care for cancer care for everyone, and my job was to do that for veterans. So I brought artificial intelligence into the VA system and created a personalized medicine program to help veterans. Off to the right, when I worked with President Trump, I asked President Trump for help in expanding technology to better care for veterans, not only with cancer, but also with other diagnoses. And I asked for his help to allow us to use telehealth in a much broader way across the entire country. Now, today in the pandemic with COVID-19, I think everyone is used to using telehealth in a much more expanded way, but probably a year or two before the pandemic, at the Department of Veteran Affairs, I asked the president for help so that we could have veterans treated at any part of the country by clinicians in any part of the country. In the United States, licensing is done at the state level, and that prevented us from allowing a doctor in New York City to help a patient who was in rural Wyoming. But thanks to President Trump's help in this, we were able to get the expansion of telehealth to every part of the country for every veteran in the department. That really was a big help once COVID-19 started to appear, because VA already had a very effective telehealth system in place, the largest implementation of telehealth anywhere in the country. Now, we were using that then to expand our telepathology services. VISN 8 is a region of the country. That's all that means. But this is how telepathology was being used for consultations, for second opinions, and frankly, to reduce the geographic barriers. That means to allow pathologists with specialized expertise to be able to help patients with diagnosis of cancer anywhere in the country. And this was really a dramatic expansion in the capabilities of the Department of Veteran Affairs. So with the regulatory changes that we were able to get in place and now are in place for everyone in the country because of the COVID pandemic, we're seeing a dramatic expansion of telepathology services. Now, I do want to sort of step back just a few minutes and talk about why these technologies like artificial intelligence and machine learning and even some of the remote monitoring capabilities seem to be so slow in terms of getting disseminated throughout the US healthcare system. And there are three fundamental reasons that I always think about when we look at why are things not working better in the US healthcare system. And they really have to do with the fact that physicians and providers in general and payers are not incentivized in the same way. So that often what is good for a provider to do financially turns out to be bad for a payer, or vice versa. What's good for a payer turns out to be bad for a provider. And that just slows down the whole system. That clearly was the case using telehealth, and clearly is the case using artificial intelligence. If we replace physician interpretation, physician income will go down. And so there has to be better alignment of these incentives. The second problem in the US healthcare system is that the way that we have created our insurance coverage and our insurance product design is that consumers still generally have a very small share of cost. And so therefore there's a disconnect between what consumers think that they deserve and want and the payment system. And that doesn't exist in most other markets, and so therefore creates some unique problems. And the third issue is that if you were to create something that looked more like a traditional marketplace, consumers and providers and payers have very little ability to look at what true costs are, price transparency, and also what the outcomes of care are. So there's really no connection between what one's buying and paying for and the value that they're getting. So those are the three fundamental flaws of our system that I always look at when I try to explain why something is working or potentially not working or going slower or moving faster. The truth is that while we call the US healthcare system a system, it really is not a true system. It's just a bunch of individual components that aren't always connected. And I think the pandemic in COVID-19 has really exposed a lot of the fragmentation of the US healthcare system and shown the gaps where the system doesn't really yet work together. So we have government that now is paying about 50% of the healthcare bill. We have the providers, which are the doctors and hospitals. We have the payers, the insurance companies, we have patients, and then we have the capital markets and the healthcare industry themselves. And each one looks at the healthcare system somewhat differently and approaches care somewhat differently. Some people on the call may be interested in how the Biden administration may impact this. Are they going to change some of these incentives? Will there be an ability to speed innovation? Will there be more money that's put into the healthcare system? With a United States Senate that's divided 50 Republicans, 50 Democrats, I think that what we're looking at is a governance or legislation or the way that we're going to be looking at healthcare policy much more from the center rather than from either the left or the right political perspective. And I think most people feel it's very unlikely that we're going to see major changes in the way that healthcare is delivered in the United States. Rather, we're going to see incremental or marginal changes that, while they can be important, will not fundamentally change the way that healthcare is delivered. And much change in healthcare in the United States is actually done not so much by Congress, but through regulation. So regulation is done by the agency that's part of the executive branch. Healthcare is generally run by the Health and Human Services Agency, and they don't do that much through legislation. Obviously, if Congress wants to change the way that healthcare is delivered, they can pass a law. But what I'm saying is, in a 50-50 Senate, that's not likely. So you're going to see most of the changes done through writing different rules and changing regulation that does not require congressional approval. Now, President Biden, who many of us have known for a long time, and as I said, I worked with him in the Obama administration, has a fundamental belief that healthcare is a right of all citizens. And so what he really wants to do is expand access. He wants to see all Americans have access to healthcare. Right now, as you know, we have more than 40 million Americans without insurance in this country. And the way that he wants to do that is very much along the way that the Obama administration was doing this. He wants to strengthen the Affordable Care Act, which is going to include more subsidies for insurance exchanges. And you've already seen more executive orders signed by President Biden than any other president, because what he's really undoing, what he's doing in these executive orders is undoing the work of the Trump administration that was trying to limit the effectiveness of the Affordable Care Act. They couldn't get a congressional change, and they couldn't get the Supreme Court to change the Affordable Care Act. So what they did was, through executive orders, the Trump administration really put barriers and limited the effectiveness of the Affordable Care Act. And you're now seeing President Biden roll all of those executive orders back to make the Affordable Care Act more robust and to be able to expand it. You're also going to see President Biden supporting some of the work that had been done in the Trump administration under cost and quality transparency, making it easier for people to understand what these outcomes of care are and the cost of care. And also, you're going to see continued support for the regulations to support the ability to use data interoperability, especially electronic data. And this is going to be important for digital pathology, to be able to make sure that pathology information that is digitized can be shared easily across different electronic health record platforms, along health insurance exchanges, and is interoperable in general. The other area that you will see President Biden and the administration continue to focus on is device and drug pricing reductions. This is something that President Trump had focused on, but had not really done it effectively. In fact, some of his executive orders, like tying drug and device prices to international indexes, were done so sloppily that no one really took them that seriously. I think you're going to see a much more comprehensive and thoughtful approach during these first couple years of the administration of the Biden team towards going back to make sure that they can get some results on decreasing these types of prices. And as a result, I think you're going to see dollars shifted and more dollars being invested into the healthcare delivery system to expand access, and into healthcare technology, because that's the way that you can expand access. That's the way that you can get more efficient and get better outcomes. So just a little bit about the Biden administration. 2020 was a year for all of us that I think none of us are going to forget quickly. It was a very tough year, but it was a big year of change for healthcare. I'm sorry, that keeps popping up. And it was probably the biggest year ever for artificial intelligence. More invested in it, more being done in terms of actually moving it into the clinical setting. This is a really important year in 2021 to see whether that momentum continues. I'm going to talk to you about why I think it probably is likely to continue. Oops. I'm sorry. Maybe we lost the video. I hope not. But I'm going to keep talking, hoping that you can still hear me, even if you can't see me. The impact of COVID-19 on hospitals is something that I think all of us need to pay attention to. What you're seeing in the United States on hospital finances, which will drive whether there is money to invest in these technologies like artificial intelligence, is going to be a big deal. And what you're seeing in the United States is very geographic differences between hospitals that are suffering tremendously because of COVID-19 and others that have actually done fairly well. So it's a story of the haves and have-nots. But overall, the industry has suffered considerably. You've seen a decrease in admissions, a decrease in emergency room use, a decrease in surgeries, in ambulatory procedures. All of that translates into a reduced hospital margin, reduced revenue, reduced ability for hospitals to invest in new capital projects. And so that's something that I think that we have to keep a very, very strong eye on. One of the things that may or may not be evident to those of you outside the United States is that, okay, I apologize. I'm getting messages on here that I hope that you can hear me. But one of the issues for those of you outside the United States that you may or may not be aware of is that the Medicare system, the government system for paying for healthcare, largely for people 65 and older, is due to become insolvent, in other words, run out of money by 2024. That's a big deal that that's happening. One of the reasons it's happening is because the pandemic has accelerated the reduction of revenue into the Medicare system. So that is something that's going to have to be dealt with very soon at the national level. With that happening, one of the results might be that Medicare may have to reduce payments to providers. That will even add additional financial stress onto the provider system. So providers are going to now need to take costs out of the system with a focus on labor. The reason why I'm saying their cost reduction efforts will likely involve a reduction in labor is because 60% of all of hospital budgets are focused on people. It's a very people-intensive job. And the way to take costs out of the system is to find technology that may end up increasing productivity and reducing labor costs. Secondly, providers are going to be under much greater pressure to reduce the variability of quality. So if you are having a lot of misdiagnosis in your pathology readings or poor outcomes in cancer care, that is going to be something where there's going to be increased attention over this next year on those types of results. Scale is becoming really more important in the United States as big corporations are increasing their footprints. You're seeing increased merger and acquisition activity in every part of the healthcare sector. And that means that when you have scale, it's going to be a greater opportunity to put technology in place and to get value out of technology. On the payer side, this year coming up, it's a very interesting year. 2020, as you may know, even though the pandemic was in full rage, actually resulted in better financial results for payers. And so this is that mismatch that I was talking about in the US healthcare system. When payers do better, providers often do not, and vice versa. And so the medical loss ratio, how much payers spent on medical care, dropped to record levels during the pandemic because people were not seeking healthcare. They weren't getting healthcare services. And so the profits went up. But most payers are predicting a return, in fact, a backlog of procedures that weren't done in 2020 might happen in 2021. So they are very nervous about what's going to happen to their financial performance in 2021. And therefore, many are acting conservatively. Even though they have a lot of money in their capital reserves, they are scared to spend it unwisely because they're unsure whether they're going to have to pay for all this deferred or backlogged healthcare. So it's going to be interesting to watch that. Payers are looking for opportunities to therefore take some of the profits that had occurred in 2020 and see whether there's a way to look for projects or technology or new partnerships in order to change the way that healthcare is being delivered. Many are partnering with provider groups, often physician groups, in new types of risk arrangements where each will benefit if care can be delivered more efficiently. And many payers are acquiring providers, physician groups largely, and companies so that they can expand their footprint both horizontally and vertically. In the capital markets, we are seeing more money flowing into healthcare investments than ever before. The numbers are absolutely extraordinary. And the focus is often on this value-based care, on how do we improve the delivery of care to get better costs, to get better outcomes. So digital pathology is one of the beneficiaries of all of these trends. And the global market, as you probably know better than I do, has been relatively increasing at pretty considerable rates. About 11.7% each year is predicted. And so therefore, you're going to see the digital pathology market cross the $1 billion level in the relatively next few years and just continue to grow. And the reason for this is because digital pathology really is one of those technologies that I think meets the criteria of value-based care, improving the efficiency of how care can be delivered, that is lowering the cost, and potentially, when combined with artificial intelligence, improving the outcomes and quality of care. So it really hits a lot of the criteria that you would expect would grow. Patients themselves are changing, and I think the pandemic has really accelerated this in ways that people didn't anticipate. We've certainly seen much less preventative care and much more conservatism on elective healthcare services. Patients have sort of said the things that I thought that I always had to do, I guess I don't have to do that much. And so that's changed the behavior. We've seen them embrace technology with telehealth, and that has disrupted traditional provider relationships. People can get on their computer and get immediate access to a provider, but not necessarily with their provider. And they found that that's okay. And the idea that people are going to have lifelong relationships with providers is beginning to be rethought. And clearly, I think they're becoming more tech-enabled in general, getting much more used to getting their medications at home, getting certain healthcare physiologic measurements taken at home. And you're seeing this whole tech-enabled economy now coming into the home for the provision of healthcare, but also the interaction with technology through electronic health records and other things that had been slower to adopt before the pandemic. Precision medicine is one of those areas that I think people now are beginning to see fits well into all of these changes that we've talked about. And so when you look at precision medicine as a tool, whether you call it artificial intelligence, whether you call it genomics, whether you call it just the ability to do large data analytics for the improvement in healthcare on an individualized level, all of this is coming into the play on how we think about digital pathology. One of the things that I did at the Department of Veteran Affairs is to use that data to help consumers understand the differences in quality of care. So I would publicly display all of our healthcare quality data on the internet for veterans to be able to see. This is an example in Tampa, Florida, where the Super Bowl was just held, where veterans can see exactly what the data in their VA says, what the quality data says, compared to all the private hospitals in the Tampa region, so they could make better informed choices. And I think helping consumers understand who is using technology to help them get better outcomes, which hospitals are using digital pathology, which hospitals are using artificial intelligence and getting better results, I think it's going to be the future of where we're going in the United States. So is digital pathology inevitable? I think that what I've been talking about so far really says that yes, the answer is it is inevitable. And the reason, again, not to be too repetitive, this digital pathology fits into the need for cost reduction, for quality and transparency, for the ability of technology to provide those solutions, and capital dollars are flowing in for those types of investments. Now, when it comes to artificial intelligence in digital pathology, we all know that there is an increased workload on our pathologists, that the cancer incidence is increasing at the same time that there has been not the same corresponding increase in the number of new pathologists entering the market. So that's getting to be a shortage of pathologists as we're seeing the age of pathologists increase, retirements, burnout that's happening, and this trend of increased workload with a shortage of pathologists is creating a need to implement artificial intelligence and digital pathology. We also know that pathologists can often disagree with cancer diagnoses about 9% of the time. And you can see a change in the Gleason grading by pathologists almost 1/3 of the time. So here again are those factors of their variability and quality differences, their economic reasons, and fundamental staff need issues for artificial intelligence. This pathology gap that I talked about, the shortage of pathologists, you can see the anticipated demand growing, the anticipated supply relatively declining, and so therefore this is not likely to get better anytime in the near future. We see an increase in digital workflow of about 21% when digital pathology systems are put in place. That's a pretty big increase in the ability to have diagnostic capacity to increase your productivity, essentially, 21%. I don't know of too many examples in healthcare where that can be done as readily and get those types of results. Now, the state of digital pathology and artificial intelligence in prostate cancer, in reviewing the literature, there's already about 185 articles that are looking and have reported on, many peer-reviewed, on image analytics with artificial intelligence and readings. Looking at reports from around the world, in France, but also in the United States, prostate cancer using artificial intelligence is being interpreted with a 98% sensitivity and a 97% specificity. That's pretty impressive. Investigators are able to detect the differences using artificial intelligence between low-grade and high-grade tumors and perineural invasions. And out of a review of 941 cases using AI with digital pathology, there were 17 misdiagnoses identified in the US population of these cases and 12 misdiagnoses in France. In August of 2020, an article was published in Lancet on the use of artificial intelligence for prostate cancer. It was a blinded clinical validation study done at the University of Pittsburgh in Pennsylvania. And to me, this was a really important study. What it showed was that even at a major academic center like the University of Pittsburgh, there were 6 cases that required a change in diagnosis using artificial intelligence compared to human reads, and that the prostate cancer detection using the AI system had a sensitivity of 98%, and there's your specificity of 97%, the area under the curve at 0.991. So this really demonstrated in a peer-reviewed journal very, very good outcomes associated with AI readings for prostate cancer. How about in breast cancer? There was an article in Nature in January 2020 showing using AI that there were more accurate readings for mammograms than with human radiologists in the UK and the US. Reduction of 1.2% in false positive readings, a 2.7% reduction in false negatives. And look at that, the reduction in workload, 88%. So that's really significant. And as you know, there are shortages, at least in the United States, of mammographers. Very, very hard to find good qualified mammographers. Let's take a look at some of what these AI readings look like. This is from a company called Ibex. that is looking at breast cancer. You can see the heat map or the red showing the area of pathology that's being identified and the way that the AI can identify those areas for a pathologist to review. Ibex has 3 ways that they work. They help just identifying a more efficient workflow for where a pathologist can focus their attention. There are second reads that take a look at what a pathologist has already read, putting it against a artificial intelligence algorithm to see whether any additional cases can be picked up or identified. And then in general, as a quality review program, to look for patterns and issues earlier in the process for a improvement process, an educational process to make pathologists more aware of opportunities for improvement. So all 3 of these are applications today that are being used. As we've talked about before, even though these technologies are already showing that they can be quite effective and save workload, technology adoption is very, very slow, particularly in the United States. And I just want to really finish up here and then leave a little bit of time for questions, just talking about some of the work that that I've been involved in, if people are interested in learning more about it. Off to the left is a book that I've recently written called It Shouldn't Be This Hard to Serve Your Country. It's about my experience as the secretary and the undersecretary of the Department of Veteran Affairs in running the VA healthcare system and the issues and the approaches that I took towards trying to improve it. A lot of this has to do with population health, with artificial intelligence, the use of technology, and it lays out a fundamental game plan for how we can make these improvements across big health systems and make them work better for our patients. The book to the right is a book that I wrote with others in the Department of Veteran Affairs that takes these approaches and learnings from parts of the VA system to spread them throughout the country, best practices that have been identified to allow us to implement even better improvements across the healthcare system. And a lot of this has to do with what we've been talking about here today. So those are 2 resources. And then finally, something that I've recently started and become involved in is trying to figure out ways that we can help countries share knowledge with one another and how we can take this technology and really make it available to everybody across the world. And, you know, obviously I'm a US-based person, and so I tend to think about things from an American point of view, but recently I've begun to really appreciate how much innovation there is around the world that can be brought to the US, but also to different parts of the country. One of the companies that I mentioned in artificial intelligence in pathology is Ibex. Ibex turns out to be an Israeli company, and we're working with them to bring that Israeli technology to the United States, but there are certainly other opportunities. And one of those is a collaborative that I've started between Israel and the United Arab Emirates to share ideas and technology to bring this to different parts of the country. So this is IsraelUAEHealth.com. If there's people from the Emirates or from other parts of the world that are interested in learning more about that. Here is my contact information, my email, my Twitter. I'm also on LinkedIn if people are interested in connecting or finding out additional information. And with that, maybe I'll just leave a little bit of time should there be any questions. I know that there was an email link that people could send questions in for, but be glad to talk about any observations that people may have in artificial intelligence and digital pathology or other questions about the US healthcare market.
Thank you very much, Dr. Shulkin, for sharing this valuable information with us about digital pathology, artificial intelligence, and your work for veterinary affairs. We are pleased to have you with us, and it was an honor. So, has anyone got any questions to ask, please?
Yes, I have one.
Yes.
I'm Mike Redsky. I gave a talk prior to Dr. Shulkin. I respect your ability to negotiate the distances between the various players in the medical field. I've had a lot of problems trying to solve a problem that's going to take money out of the system. So what's worked out for me is to address this Nigerian breast cancer problem. There, no one objects. If we can solve that Nigerian problem, no one would suggest. But I applaud your ability to negotiate these systems.
Well, Michael, I do not claim to have a secret sauce to get the system to work better together. But, I do like your approach, which is that if you can demonstrate success in one area, that tells people that it's not impossible, and it shows them a way, and it creates a model and a show one, do one, teach one is the way that medicine often advances. But, right from the beginning of my career as a physician, I went and got training in behavioral economics. And so I always approach things that if you don't try to address what the right incentives are, and if you don't try to align those incentives, it's just a lot harder to get people on board. Most people in healthcare want to do the right thing. They want to help patients. That's why most of us went into this field. But when you're asking people to do things against their economic interests, it slows down. So I always look to try to get the right elements in place before you start a major change initiative. But, I applaud you for trying to show that there is a way to do it, because that's the way you ultimately change people.
Thanks.
Excuse me, can I have one question?
Sure.
Yes, please, can give us about little experience about the misdiagnosis in pathology and how you react in this if this scenario happen in USA.
Yeah, well, it happens all the time in the USA, and so I think that as opposed to clinical medicine, like I practice as an internist, there can often be different interpretations and judgment issues. But when it comes to pathology, you have a specimen, and if it's diagnosed improperly, you're going to have an expert to be able to go back and point out exactly where you misdiagnosed it. So it's much clearer when these diagnostic errors happen in pathology, and that's why I think using a artificial intelligence system as a backup system, as a check of the work, as a way of helping a pathologist see where they should focus their attention so they don't miss something. I think this is what has to happen. I mean, because it's good for pathologists, it's good for patients, it's good for payers. And so I think that this is natural. What I was surprised about, again, saying that unlike most of you, I'm not an expert in pathology. I was surprised at how often these misdiagnoses occur. 12% of the time, pathologists can disagree at looking at the same slide. They can, have a difference in the grading level in prostate or breast cancer. So this just says to me that this is the perfect place to try this type of new technology in pathology.
Because what is what I face it regarding this issue is very sensitive. You will find even personal resistance from others colleagues regarding changing diagnosis or give them another opinion. So the primary, usually he refuses it to take the experience of the other.
Yeah.
So did you have a solution or you face it, this problem?
Yeah. Look, I you know, the good thing about getting older, as you know, some of the people on the video can certainly probably relate to is you know, you've seen all this before. So, you know, I've been working with physicians my entire career, and this type of defensiveness and saying, you know, I don't have a problem, it's always somebody else that makes the errors, and you know, you know, I don't want to change. As I get older, I honestly have less tolerance for that. I mean, it's just simply not true. Everybody makes mistakes. Everybody can be helped with a safety net if you really care about patients. And so, you know, I would say to the person that was resisting that, would you want to fly on an airplane where the pilot says, I know how to get there, I don't need radar, you know, I don't need to be told if I'm getting off track because I've flown this location, you know, so many times. So, you know, I'm now, you know, having led as many health systems as I have, when I hear those type of arguments, you know, I try to understand, I try to be empathetic, I try to explain and show the data, but ultimately, I am willing to show that person the door and tell them, find another place to work if you don't believe that you want to be part of an environment to get safer care.
Yes. Okay, Dr. I would ask you, how can I get your book?
On Amazon.
On Amazon. Okay. Thank you. Thank you for your.
Sure. Thank you. Yeah.
Thank you very much for your time.
Thank you. Great.